Welcome everyone. Today we're delighted to host two outstanding physicians who've been trailblazers in the world of lasers. And they're not just here to talk about their groundbreaking work, but also because they're both from North Texas, maybe we'll coax them to share their top barbecue spots. Well, first up, let's give a big welcome to Dr. Drew Sanderson. He is from Flower Mound, Texas. More than a renowned plastic surgeon and otolaryngologist, Dr. Sanderson is also known as Lieutenant Colonel Sanderson, marking his impressive 13-year service in the U.S. Army Reserve. His unique blend of medical expertise and military experience has made him a standout in his field, respected both for his skills and his approachable demeanor. Now just drive down Interstate 30 east from Flower Mound, and before you know it, we reach Tyler, Texas, home of our second guest. Let's show our enthusiasm and welcome for Dr. Jennifer Holman to the stage. Dr. Holman is a dermatologist distinguished in her expertise with Botox, fillers, laser hair removal, and PRP, and she's deeply committed to enhancing lives through advanced skincare. She often says, restoring balance and peace of mind to my patients through effective treatments is the most rewarding part of my work. Well, now that we've met both of our experts, it's time to talk lasers. Welcome to the conversation.
Thank you guys. This is really fun to be here, and I always love speaking with somebody who's trained in plastics and someone who's trained in dermatology, because we tend to think about cases a little bit differently, and like there's not one right way to do things, so this is always fun.
Yeah, absolutely.
And so we're going to kick it off. We're going to start with one of my cases today. This was a pretty challenging case when you see it walk in your door. So this is a gentleman with some of the most severe rhinophyma, or it's a phymatous change and an overgrowth on the tissues of the nose. You can also see it on the chin too. It's associated with rosacea. And so really when you look at this, there's only about one thing that you could do. Historically, we've treated these cases with loop cautery. The downer with that is it's messy, takes some time, but it also really leaves the nose with a very, very white scar-like appearance. And sometimes, especially if they have existing rosacea on the rest of their face, you've got this white nose compared to a red face. And so you saw a lot of scarring with that procedure. And so what did we do in this case? So this is him when he came in for his touch-up treatment, but this is where I love my TRL, the tunable resurfacing laser, that's the erbium wavelength. It's kind of the only thing now that I do for rhinophyma. And in this case, we did another touch-up today. You do have to do blocks or local anesthetics when you're doing this. And my caveat here is that this is also a very tedious and also very bloody procedure, because once you get into those vessels, you've got increased vasculature because of the rosacea as well. And so some tricks that I've picked up: soaking gauze in dry sol, soaking gauze in lidocaine with epinephrine, using that as you go. Sometimes I'll even use a little bit of cautery as well. But you just turn up the microns and you just keep going until you get to your end point.
That's a tremendous result, Dr. Holman. Can you speak a little bit about your post-op care of him?
Sure. So in cases like this, number one, they're going to be eroded sometimes for a couple of weeks.
Yeah.
So you really have to emphasize, don't let that tissue get dried out. Even if it's with Vaseline or Stratamed, one of those other products, we want to keep that tissue very, very moist during the healing process, because if it gets dried out, what is a scab? That's necrotic, dead tissue. And so we're not going to get as good of a result. So you physically have to keep it occluded and moist for about 2 weeks. The other thing that you need to know is cases like this, and a lot of times, anytime I'm doing TRL, perioral, it may be better in your hands, but sometimes I'll have patients with a good 90 days of post-procedural erythema. Once they're healed, they can wear makeup. This guy's not gonna wear makeup, but it's important as you're educating patients in these consults that you really can have some significant post-procedural erythema. It doesn't last forever. You can certainly BBL it as well. That helps also, but that's, keeping it moist and occluded. Thoughts about how you handle this in yours?
So this is the kind of patient when they walk into my office, I go, thank you, God, because you know you're gonna be able to hit this home run, and it's just the before and afters are so impressive. And I actually still will use loop cautery for the most superficial stuff. And then once I get to begin to kind of get what the nose, rough shape of what the nose is gonna look like, then I'll switch over to my erbium contour TRL and start blasting away and shaping the nose. Let me ask you this. what kind of endpoints do you look for, and when do you stop?
So for me, in cases like this, unlike when I'm doing resurfacing around the mouth, looking for signs like Dr. Burns has taught us of particular kind of bleeding, here I'm looking for the shape and size of the nose.
Yeah,
And so,
sure.
I may do some surgical debulking first and then use that TRL so I don't have the scarred appearance and really restore some shape there. But in cases like this, again, I did do a little bit of touch up here. He doesn't care that much other than it's so much better. So I doubt I'll never get like the final after picture. But this is a fun one because you really do have the blessing to be the person that gets to change someone's life.
Absolutely, and men will often, give you a couple of follow-ups and then say, okay, I'll call you, don't call me. Yeah. Okay, so this is next case is one of mine. So this is a 42-year-old woman. The Mohs surgeon called me the night before and said, hey, I'm sending you a patient. She's reasonably young, beautiful, has a big cancer on her upper lip, and it's going to be a big wound. So, she sent me a picture, so I kind of had that in my head, and I was planning on reconstructing it the next day. But it's one of those cases when you see this woman with this cancer and knowing it's going to be, at least the size of a quarter when she finishes the excision, you lose sleep over that one, So I had my plan. You can see the wound there. It involves the majority of the central part of her upper lip down to muscle. It involves a vermilion border, and including some of her red lip. Takes out most of her philtrum, as you can see. So it's a tough one to reconstruct. You think subunits and reconstructing the subunits, but I elected to do kind of these bilateral upper lip advancement flaps to the midline. And, scars hide really, really well in the nasolabial folds. So if you have to extend it there, you can. And this is the probably 3-week post-op picture. And at that point, it just takes some hand-holding with me. And I'll start the hand-holding and predicting the future, so to speak, even before she has her excision. And I'll say, look, this first post-op visit is just gonna be your first look. This isn't how it's gonna look when we're done. This is just the very beginning of the journey. And they like to know that we've got a lot of things we can do to make this a lot better. And she was fortunate that she had the funding which allowed her to do a little filler, do some laser work on her scars, and she eventually got a lip implant and got a pretty good post-op result. I did about 3 different profractional treatments of 500 microns to improve those scars, and started with velour in her upper lip, in her lips. I put about 1 syringe total. The majority of that syringe went into her upper lip first, and it just kind of helped me rebuild the central part of her upper lip. And then once we were there, she liked the way it looked. And I said, well, we can consider a lip implant at that point, and that's essentially what we did. When I do the profractional treatments, I will massage a little bit of Kenalog into the area. I like doing that. I think it helps. And her scars speak for themselves, I suppose.
That's fantastic results. I'm a Mohs surgeon as well, so one of the things that I love when I'm treating young patients or patients where I know it's going to be like, I can do my very best repair and I'm still going to need to do some work. While I'm doing that repair, I'm already telling them, guess what? We're going to get you scheduled for a laser treatment with me because of what it looks like, very similar.
Yeah.
What it looks like at a week, what it looks like as a month is not what it's going to look like. We're going to get you there. So a couple of questions I have for you, just curious how you do things. How far postoperatively will you do your first profractional treatment?
Yeah, thank you. 3 weeks. I'll start them pretty early, yeah. And pretty much all of my surgical scars, there's certain areas in the body that you get a little bit of wound dehiscence. Like when I do a breast reduction where the vertical scar meets the horizontal scars, that'll break down a little bit. And I tell them that ahead of time. If it happens, don't worry about it. It's going to be fine. If that's the case, I obviously won't profractional that part. Otherwise, every reasonably well-healed scar will start at 3 weeks. And if we can't get them in at 3 weeks, anywhere from 3 to 6.
Okay. The other question is, do you charge your patients for this profractional treatment?
In her case, I did. Would I have done it had she not been able to afford it? Absolutely. I include my post-surgical scar profractional treatments as part of the surgical fee. Yeah. And it works really well because I love my laser technicians in my practice. I think they're wonderful at what they do. And it gives my surgical patients an opportunity to meet them and kind of understand what some of the things we do on the med spa side. So it just kind of helps both grow both sides of the practice.
Yeah, that's fantastic. The nice thing is if you choose not to charge for these treatments, you don't have any disposable costs with our profractional laser, and it takes you all of about 30 seconds to do these treatments. And so it's a great, I use my professional handpiece probably every day.
Yeah, yeah,
I mean, it's a workhorse for me.
it is.
It's a beautiful result.
How quickly will you pro-fractional your?
Usually I'm about 6 weeks. I mean, I may,
Yeah.
after talking to you, try it a little bit earlier, but usually I do about 6 weeks. 6 to 12 tends to be where I'm typically treating, letting a lot of that erythema go down. Sometimes I'll also do a little BBL before I do the profractional if there's a lot of vasculature with it, or clear V as well if you've got those telangiectasias. But lots of different ways to do it. I mean, you still get great results.
Yeah, I did BBL on her as well. I didn't mention that. I did 560 filter, 20, 15, 20, so 20 joules, 15 milliseconds, and then 20 of cooling with the small round adapter or the small round crystal. And it helps. It pulls the red out. I'm hesitant to do it on high fits 3s and fits 4s because I just don't want to hyperpigment the scar. I've done that before.
I agree.
But
Will
fits
you
1 or 2.
pro-fractional those darker skin types?
I do, definitely.
Same.
Never any
Same.
coag, but definitely pro-fractional.
I'm the same way. All right, so this is a sweet woman who really suffers from severe erythematotelangiectatic rosacea, lots of those broken blood vessels through there. And she was to the point, like she absolutely would not leave the house without a lot of makeup, but that really dark, those purple vessels, sometimes those still show through makeup as well. Very embarrassed by her rosacea, little bit desperate when she came and saw one of my estheticians there. She sends me the picture. She's like, hey, Holman, what do I do on this one? And so I gave her very, very clear settings on what to do. And so proud of my team. They do such an outstanding job, both emotionally caring for these patients and delivering great treatments. So this is pretty amazing. This is just one BBL. A few pearls that I did here, and obviously we wanted to see her back because I figured we were gonna have to do some cleanup. And I actually, now that we have the Clear V in the practice, I'm gonna do that cleanup with the Clear V 1064 wavelength. But what I had Alicia do in this treatment was the BBL Hero first, a standard treatment. I did the 560 filter for that, and that's mainly because she has got so much vasculature that she is going to swell significantly because you can get significant swelling just from a BBL or BBL Hero, especially up under the eyes. But when you are this red and this many broken blood vessels, you've got to educate patients that they need to sleep propped up. Gravity needs to take that lymphatic swelling down, but they need to expect to be swollen for a couple days. This is not a no downtime BBL, but fantastic. So she did the 560 filter, a more traditional Hero setting, and then she went back with some of these specific larger vessels, put on that smallest spot size adapter and did a 20/20 single pulses at 20 degrees as well. And I think this is really a fantastic, but this kind of shows the quality. You can't do this with traditional IPL, but able to stack all of those passes at that small pulse width, lower energy, beautiful results. She was thrilled.
Yeah, I bet. And when you bring her back in and Clear V the remaining vessels, she'll have a completely normal looking cheek.
Right.
Yeah.
The other education point for this patient, though, will be, like, once I've got her completely clear, I wouldn't expect her to stay completely clear. Rosacea is a chronic process, and so when I'm treating my rosacea patients, do I ever want them to be this bad again? No, I do not, but I want them to stay my friend. And so these are a lot of patients who will come in every 3 or 4 months, do their maintenance, because I didn't cure their rosacea. I'm managing their rosacea, and in our hands, I honestly believe that the BBL Hero BBL is the best treatment, better than any of my medical therapies, especially for this type of rosacea. Any other thoughts there?
Will you bridge her with your medical therapies in between your BBL treatments? Or
honestly, I don't know that there's a lot of medical therapies that really help this, because if you do things that are vasoconstrictors, it doesn't work on those telangiectasias. It's really just for that flushing type of rosacea. I wouldn't think topical metronidazole would do anything in these cases. You really have to use energy to treat this. And she doesn't have any of the papulopustular stuff. Ivermectin wouldn't work here, antibiotics wouldn't work here. And so no, I wouldn't do other than sun protection, obviously.
Sure, yeah, love it. This is a woman, 68-year-old female from South Texas, had a lot of sun exposure, had a face and neck lift done in 2017 and said she just didn't feel like it lasted very long. She had a remote history of she said it was a resurfacing, but when I probed and asked a little further, it didn't really sound like a deep resurfacing. She said, oh yeah, I was red. And I said, well, could you go to dinner? And she said, oh well, yeah, I could go to dinner with the first week out. So that let me know it wasn't a true deep resurfacing. Prior smoker, but quit in 2005. And downtime really wasn't an issue. You know, you could see these fine lines around her mouth, cheek, just this thick skin thickening from sun damage over the years. And I kind of break my facial aging patients into kind of two groups. Those that will accept, you know, scars or are willing to undergo a surgical procedure to try to make themselves look more youthful, and those that won't. And I kind of go down two different education paths depending on which group that is. And since she'd already had a face and neck lift, I knew that was in the game, so kind of went directly to that point. I did a revision lower face and neck. You can never get quite as much skin out and tightening out as you can the first time. I also did a contour TRL, 2 passes of 100 units, 100 microns on the forehead, followed by 50-50, 50 of ablation, 50 of coag. On the nose, I did about 400 of ablation. Around the mouth, as well as chin, 400 of ablation with, again, 2 to 3 passes over the deep creases. So Dr. Burns talks about his island technique, and I like it a lot. It makes me feel comfortable because I can take my 2mm spot size and just blast a wrinkle away. And if I get a little too deep there, the skin on each side is going to heal. It just makes me feel more comfortable about going deeper and being a little more aggressive over fine lines around the mouth. I chose, again, profractional over the lower eyelids, and she is about 9 months out in that post-op picture. And, you know, she was happy, which is all that really matters to me.
I think she looks fantastic. When you talk about doing some of that research, so you didn't do any like lower bleph on her?
No.
Okay, well that's beautiful lower eyelid. Yeah. What pearls do you have for treating the lower eyelids for practitioners with profractional or with TRL? Like what's your recipe?
Yeah, so I'll do the snap test. I'll feel the lower eyelid, and if it takes, you know, if it snaps back quickly, I don't mind. I have no problems doing a, you know, skin pinch, pretty reasonable, not hugely aggressive lower eyelid blepharoplasty. If they've got herniated fat or bulging fat in the lower eyelid, zero problems removing that. I've gotten myself into a lot of trouble being aggressive with lower eyelid blepharoplasties, so I absolutely err on the side of not taking too much skin, not taking too much muscle. And again, my dissection used to be really aggressive. It's all gotten less and less aggressive. When I do my skin excision, I'll pull down on the cheek to try to simulate gravity a little more, and then only remove what's still overlapping. So it's not a super aggressive treatment. That's if I'm doing lower lid blepharoplasty and they've got a nice snapback with their lower eyelid. If, like her, she doesn't have a ton of extra skin, doesn't have a ton of fat, just needs better skin quality in her lower eyelid. And that's why I elected to do the profractional treatment only. I'll do 2 passes, ends up being about 22%, 2 passes of 11%. Occasionally I'll do a third pass, but I do around the medial campus, you know, where the kind of lower eyelid meets the nose, I'll never do more than about 1 pass. It's not an area that typically ages poorly, so, you know, I don't feel like I'm shorting them anything by treating it less aggressively, but I think you can also cause scarring a little more easily in that area, and that's the reason why I don't go as aggressive.
And then your reasoning behind the coag addition there, what's your thought?
You can literally watch. It's fun to do because when you turn the coag on, you can watch the dermis tighten underneath the laser, and I absolutely believe it makes a difference in when you can use it.
Do you use it in other areas of the face too, fractional?
Yeah, I'll use it around the mouth some and certainly on the forehead. I'll never use it on the cheeks. I just don't think there's a need. Yeah. I do bring all of my and I've learned this the hard way. If I'm just doing a face and neck lift, I'll bring them back at 1 week and do my follow-up, you know, my post-op visit. For a long time, I wasn't using drains and had a complication, and I use at least 1 drain in everybody now. And it's so you can pull it out. You know, I do a face neck lift on a Friday. I can have that drain out on a Monday. My deep resurfacing patients, though, I see them back. Let's say I do the deep resurfacing on a Friday. I'll see them back on Monday. I'll see them back on Wednesday. I'll see them back on the following Friday. And they may not see me, but they see the girls on the med spa side who just debride and clean their face and clean their you know, skin. And you get less infections, less complications, and you can kind of teach them how to do it as well. And if you teach them how to clean their own face a little bit, then by the last visit, they're clean. You usually don't have to do anything.
That's great. Do you take all these patients for your full face TRLs to the OR, or are you doing any like a dermatologist? I don't have the luxury of general anesthesia.
No, I appreciate the question. Not all of them. Sometimes it's a budget thing, you know. So somebody will tell you, hey, I want a lower face and neck lift, and I want a deep resurfacing, and I've got $8,000 to spend. And then you kind of have to 12,000 or whatever your number is, and you're kind of trying to figure out how we do it. And I'll never do a lower face and neck. I always I put them under some sedation every time. It just allows me to really get the platysma tight. It allows me to do better work. So I never compromise on that. If I am doing a deep resurfacing though, doing nerve blocks in the central portion of the face, and then kind of fanning out with a spinal needle in the cheeks, you get pretty good anesthesia with that and get super aggressive with it, and that's probably what you do too, is it?
Yeah, very similar,
Yeah.
very similar. And a lot of times I'm going to combine. I actually don't do as many full face TRLs as I used to. A lot of times I'm combining profractional and TRL in the areas they need it the most.
Sure.
But I think those are some great pearls. Of course, as a dermatologist, what I love is that her skin looks fantastic. It looks so healthy and young.
Thank you. Always the goal.
All right. So this is a young woman who comes in to us, and she's got a lot of sun damage. But what I want to point out, and where I encourage folks to look as they're examining their patients who come in for laser consults, those few larger spots by her eyes actually have a little bit of textural change to them, and that's what we call macular seborrheic keratoses or flat seborrheic keratoses. You got to get those off, and just the BBL is not going to do it. And so one of my very favorite tools that I use, again, much like my profractional, I use that little spot every day. Like, it's very hard for me even to do just a BBL if they've got some sebaceous hyperplasia, if they've got some of these flat SKs. It's just hard for me to know that they left my office without me doing the very best thing that I can. And a lot of times I won't even charge if I've just got a couple of sebaceous hyperplasias, because I'm doing it more for me than anything. But so this is her, and this is what she came in with. And here's her after. I think this is absolutely beautiful.
That's a home run.
Yeah. Again, similar to your patient that you saw, this is healthy, glowing skin, which is always what I kind of talk to my team about. Like, that's our goal. We want very natural results. We want very healthy results, because healthy skin to me is the hallmark of youth. More so than anything, if someone comes to me and says, I've got this budget, and we're talking versus like sculpture or fillers or neurotoxin, I'm going to vote for spending your cosmetic dollars on your skin.
Sure.
Every time. And so what we did here is we start with the BBL Hero. And for me, I would say 99% of my BBLs on the face start with a Hero step, and 100% off the face are Hero as well. I just think you get so much more safety. You're able to get a lot more tightening with the Hero settings, because overall we're delivering a lot more energy into the tissue as well. And so we started with the 515. I think it was at a 6, and 3 for the milliseconds, 4 for the hertz, and my guess is it was either a 20 or a 25 on the temperature there. We start with that, and what you see as you go through all of those pulses is that all this brown stuff just really starts to come to the surface. If she has any vasculature, which she did kind of centrally around the nose, I'll go back and spot treat that, 1064, or if you have your 560 filter, your 515, whatever your preference is on vascular. But typically I am gonna go back and spot treat any vasculature that I see, and then throw my 515 with that 11 millimeter spot back on and spot treat any brown spots. Usually for me that's 13 or 14, pulse width of 10. You're doing individual pulses and temperature of 20 to 25, depending on the Fitzpatrick skin type. That's my first step. The second step that I do is I take that spot TRL, here it was the 4 millimeter, and I set it on 10 microns, and then 10 hertz, and it just goes pop, 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 pop. And so I'll do a few passes like that, take my gauze, wipe it off. Typically what I see is that first pass, because I'm kind of going like this, I'll get the center of the lesion, do it again at the periphery of the lesion, wipe again, and you go until you see that they're gone. And it's a little bit pink afterwards. They do have to keep it moist, Vaseline or Aquaphor for a few days afterwards, just because it'll heal more quickly if they don't let it get kind of scabbed up. But the cool thing is, unlike, and clearly as a dermatologist, I'm like the queen of cryotherapy, especially in clinic. But the nice thing is, because you're just being so superficial and careful with just 10 microns at a time, remember that's like 1/10 of the epidermis. When you're doing it that way, you get a whole lot less post-inflammatory pigment change. You'll see people all the time. Look at some of these farmers' arms, especially here in Texas, that have been cryoed 1,000 times. They are white and speckled all over. You'll do that to her if you freeze something too hard as well. You get so much more precision with that spot TRL. Again, it's hard for me in cases not to pull it out and to put it on there. In fact, my staff leaves it on there the vast majority of the time because they know that it's hard for me to do a BBL without touching that. And the next step that we did, of course, was Moxie, and that's why she has that beautiful polish and glow to her skin. I always explain to patients that the Moxie is going to make your skin look almost like you've had airbrushed makeup applied there. And so you see this nice tightening and smoothing to the pores. It's hitting at that unique spot at the dermal epidermal junction. Would I've liked to have halo? Probably, but I still would have wanted to do the Moxie as well. And that's kind of our calm special treatment that we do is BBL Hero, TRL on anything that needs it. You do your Moxie next, and then you do your halo. You don't want to do them in the other order. The first time I did it, and it was on myself. And my skin was too hot after the halo to tolerate the Moxie, so I had to put numbing back on for 10, 15 minutes because darn it, I was going to get that Moxie in there. Learned pretty quickly you want to do that Moxie the second step. We did not take that final halo step, but if you were going to add that in, and I offer it almost every time. I'd say 75% of my folks, if they're doing their face, they're going to add their neck and their chest as well, just because we price that to say, hey, you're already there, you're already numb, let's do that. And I would say about half of my patients are also going to add that Moxie, and you just have to be able to, schedule both devices to be in your hand. But adding that Moxie step takes like 3 minutes, and so it really doesn't mean anything. She was thrilled, and now again, she can do maintenance with just BBL and Moxie if she needs to. People are motivated to take care of their skin when they get results like this as well. And so typically I get them on a good product regimen because they're willing to be loyal now to our office and our recommendations when we get results like this. And so thoughts on any of that, how you would have done things?
No, that's great. It's a couple of questions. The 2 millimeter, 4 millimeter spot erbium ablative treatment, I think is probably one of the most underutilized. And I love that thing, and I give my team a lot of freedom after education to use it. And I think they get nervous using it though. So to help folks in the same situation, what do you look for whenever you're taking away like a flat seb K like that? What's your endpoints? How do you know you're
I want it gone.
When it's gone.
Pink.
So pink skin.
Yeah. But you can't tell if it's gone unless you wipe that char off. And so tips when you're starting and getting comfortable with this, obviously if you're not a physician, make sure that your physician is comfortable with you using ablative hand pieces. I have them slow the hertz down when they first start. So start at 2 or 5 hertz. They'll get real bored with it real quick once they get comfortable with it. But 10 and 10 is where I think pretty much everyone in my office operates as well. They've watched me do it enough that they've learned, and I have a very mature team, so I feel very comfortable with them doing that. But there's so much safety because you're only going a few microns at a time. As long as they're not holding it in one spot and doing like 20 or 30 pulses, which none of them would. But your endpoint needs to be, I want to see that pink tissue, tiny, sometimes little pinpoint bleeding, just because you're in the upper, the papillary dermis, where you are going to have a few little small vessels that dive up there. But yeah, endpoint is gone.
Do you have it's fun to talk to a dermatologist in this setting, but do you have a lightener of choice that you prefer?
Being at my cosmetic office, I'm one that's all over the place. I have a compounding pharmacy sheet that's literally like 8 font, both sides of a paper, because I do like to use a lot of topical medications. When I'm at my cosmetic office, I tend to go more for medical grade. C+ Illuminate here would be a great one for her to use. Even Tone as well, because she's got some reds by Skin Better Science. She's got some reds and some browns. But again, starting with that stuff wouldn't do anything in this case. You've got to start, that's your maintenance that you go to afterwards, to give her a tube of something, which is what a lot of dermatologists do. I get it. Everybody doesn't have the blessings of a Sciton in their office where you can treat safely like this.
Yeah, I love it. Nice work. So our 6th and final case. This is a woman who was 58 years old, a lot of sun damage. She had worked with horses a lot and still enjoyed doing that, but just stated she felt like she looked tired and older than she was, and wanted to rearrange it, And I said, well, how much downtime do you have? And she goes, it's not an issue. And I said, well, how long can you be away from your horses? And she said, how long do I have to be away from my horses? And that's always the answer they give you. And my answer is usually, assuming no complications, you can be back with them at about the 2.5 week mark. I keep them away from it otherwise, just for infection prevention. She's a non-smoker. And here's what I did. I ultimately did a deep resurfacing, lower face neck, primary, not revision this time. I do frost sutures anytime I perform contour TRL on a patient's asleep. And it's essentially sewing the eyelids closed. That way I don't have to worry about her moving, even under anesthesia, and any risk to the eyes. It also allows me to treat a little bit higher up on her lower eyelid without being worried about hitting the globe. So frost sutures to protect the globes. I did 200 microns on her forehead, followed by 50-50 of ablation and coag. If you haven't tried coag on the forehead, do it. You can see the dermis tighten as you do it. 200 microns on her cheek and nose, and then 100 microns around her mouth and chin, and probably did about 4 passes. I've done a lot more than 4 passes, and just looking for the type of bleeding that we're looking for. I've probably done up to about 8 or 9 passes around the mouth with it, and it seems aggressive, but I know I'm safe unless I start to see that bleeding. It's always flattering to me when they come back tan and with a more youthful haircut. I didn't suggest that haircut. I wouldn't know how to suggest that haircut, but it's always flattering to me when they do that. And she was happy, which again is my ultimate goal.
She looks happier.
Yeah.
Just her baseline
Cool.
resting face looks happier there. So other pearls, because that's something that I haven't done before, is use coag on the forehead. You said you never use it on the cheeks.
I don't. I just don't feel like I need it. And I'll rarely use it around the mouth.
Okay.
It's pretty uncommon. But the forehead, I'll routinely will use it there. And if you haven't, try it. I've never once used it and said, I'm sorry I used that. Yeah.
I'd be curious, so what's your post-care kit for these fully ablative?
I'm pretty conservative with this, CeraVe and Cetaphil for the beginning, and then when they come back for their first cleaning, usually anywhere 48 to 72 hours. I don't like to go more than 72 hours. I just feel like my infection rate goes up a little bit if we're not seeing them. And then when they do their first cleaning, we'll do skin nectar with elastin, and as well as washing it again with Cetaphil, and then we send them home with that as well.
So you're having them cleanse with Cetaphil, not
Correct.
anything antibacterial?
That's correct, in the beginning. And then, skin nectar, at post-op day 2. And again, I haven't regretted that protocol.
How about for any of your other procedures? What other products do you use for like halos or those kind of things?
Yeah, it's pretty similar. I'm a little, halo, I'll have them, get going with the nectar a little faster. Usually post-op day 2 for sure, post-treatment day 1 or 2. And and again, never really felt like I regretted it. And I'm also not as strict with, Cetaphil. If they've got a cleanser they like at home after Halo or after Moxie, I'm okay with it. The science of the immune system being so robust in the dermis and in the skin, I get it. But I don't feel like I've ever had any allergy problems. I don't feel like I've ever had any complications from even using botanicals in those situations.
That's great.
What about you?
I typically do an elastin kit, very gentle. There's Elta makes a dermal wound cleanser that I like, or hypochlorous acid is another thing that I'll use a lot of times too, just for these patients to go home with. But I think the key, because there's so many great products out there, what I use is just my personal preference. The key is that I've always used them on myself before I send them home with patients. Like even if I'm just doing a test spot with Halo, then I'll do a test spot with Halo, because I have used products over the years with Sciton devices or other devices where what I thought was going to be good post-care was not good post-care at all. Something burned or something like, I can remember one product that like melted on my skin and just was running down my neck, which was disgusting. But trying things on myself is typically what I do. The other key with some of this, because in cases like he's showing you right now, your post-care is so important. It's like folks who get a knee replacement, like the rehab is the most important part. This post-care and the hand holding is key to your results as well. And so for larger procedures like this, and really actually for all of my halos, what I want you to take care of your skin with, even if it's Aquaphor, we send you home with from my office. And that way I know that if you didn't use it, it's from neglect. It's not because, and then we also give them written down instructions, especially in cases like this. I didn't take them to the OR, but I've got them pretty happy.
Sure.
And so they don't remember anything that we tell them in the office. Their partner's often freaked out
Yeah.
because of how they look, and they don't remember anything from the office. So calling your patients, giving them everything in writing, making sure they have what you want them to use to take care of your skin, I think is really key. As key to your results is utilizing your Sciton devices correctly and to their fullest potential.
Yeah, my preoperatively, I'm always big on trying to predict the future, because if you predict the future, then it's not a complication. It's something that can happen sometimes. And for these patients, I always tell them, you're going to look like a burn victim the first week out. You're going to look at yourself in the mirror and go, oh my God, what have I done? And they kind of understand and expect it, even though their loved ones won't. And everything we send them home with is written down as well. It's a good point.
Honored to be in the last one. Thank you guys, and enjoy the rest of your evening.
Yeah.
Wow, what a fantastic and thorough presentation. We'd love to thank our speakers for sharing their insights and their techniques with us. And we're grateful for you. Because of your interest and your enthusiasm, our third season of Laser Chat Live has gotten off to a phenomenal start. Thanks a lot for being here. Take care, and we'll see you soon.